Oh wow, that's a lot more people.
Hello, good morning, and welcome to our second issue of Implant Threads. I'm John Carney, and today we've got Dr. Tom Murphy, all the way from Portugal, who is going to be talking about photogrammetry. If anybody has any questions during the webinar, please again just pop them into the chat, and we'll get through to them at the end of the presentation. And just a little bit about Tom. So Tom Murphy's implant practice is focused on the more complex aspect of dental implantology, such as GBR, block grafting, perio soft tissue surgery, and sinus lifts, with a heavy emphasis on full arch implant surgery. Regarding full arch surgery, he is very experienced with immediate placement and immediate load surgeries, and is one of the few implant surgeons in Ireland that carries out extramaxillary pterygoid implants, transsinus implants, and zygomatics. Tom was awarded a master's degree with a distinction in clinical implantology from UCLan, and currently Tom is involved in lecturing for UCLan MSc program and has lectured for the Royal College of Surgeons England and for the ADI. In addition, Tom is involved with carrying out and publishing dental research and is currently completing a blended MClinDent in prostho at KCL. So Tom, thanks very much for joining us, and we look very much forward to listening to your presentation. So please take it away. Tom, are you there? Okay, bear with us whilst we just sort out a connection issue. Okay, so Tom's just trying to log back in. Sorry about this. He's just having a Wi-Fi issue, so hopefully he'll be with us in the next couple of minutes. Just to let you all know that our third session next month will be on the topic of full arch immediate loading with Whale Gregarious, and that will be on the 22nd of November. Again, it will be at 10 in the morning, and hopefully we look forward to seeing you all there. I think that'll be a really good session as well. Whale is a fantastic speaker and an excellent clinician as well. And Tom has just logged back in, so hopefully we can get sorted in the next minute or two.
Yep, apologies. I'm not sure what happened there. Just
That's
as you
okay.
gave me a lovely introduction, it decided to it decided to log me out. So okay, yeah, of course. Can you see the presentation now? I
We
know we had it
can,
up before.
yes.
Okay, wonderful. So am I okay to get started?
Absolutely crack on.
Okay. Thanks very much, John, for the lovely presentation. John had highlighted that I am in Portugal. I just want to mention I am not actually based in Portugal. My Portuguese would not have me paying a mortgage particularly well. But I'm just away at a conference at the moment. Thus the lovely background that you would have seen of the harbour. So we'll just get started. Yeah, we'll just get started effectively. This is just a little bit about implant threads, as I'm sure John has gone through already with you all. So we'll just start a little bit about myself before we get going. So some of you might have met me before, seen some of my lectures before. Just a bit about me. I did my undergraduate degree in Northern Ireland before doing a few different OMFS jobs for a few years between Liverpool, Belfast, and Derry in Northern Ireland. Um, my private practices are based, sort of generally speaking, for those not from Ireland, near Dublin and near Belfast, but I'm based in a few different specialist practices, sort of north and south of the border. Um, as John has said, I've did the clinical implantology degree in University of Central Lancashire, and I'm currently doing a blended implant then in PROS. So I'm aiming to cover I'm covering the PROS program, but have to submit a lot effectively to avoid me having to be in London, which is great. And yeah, as I say, the majority of the work that I do is implants on referral from other dentists or other implant surgeons where it's outside of their scope of practice. So what are we aiming to cover today? Well, I thought based on some of the feedback that we had from the previous implant threads that it was slightly, it went in at quite a high level straight away. I figured what we would start off with is say, well, let's actually just go back to basics. What is a generic full arch surgery? What exactly does it entail? What are the steps that have gone through it? So anyone who has seen me lecture before will maybe be familiar with some of the introductory slides. We're going to talk about how to do the full arch immediate load, as well as what is the more historic way of converting a denture. We can talk about slightly more novel techniques such as the smart denture conversion. And then that is when we start moving into conventional full arch impressions versus photogrammetry. I published a systematic review. John, I was just wondering, can people see me or is it just the screen before I get much further?
I can see you on my taskbar. I can also see your presentation screen as well.
Apologies to all of you who have to look at me. I published a systematic review a few years ago comparing conventional splinted impressions and photogrammetry. And at that point in time, there was actually very few well-established photogrammetry systems on the market. More recently, there have been newer systems that have come to light, although not all of them are created equal, and that is something that I would like to stress today. So we'll hopefully go through some of the various options over what systems are out there, because photogrammetry has become almost a viral topic within dentistry. Companies are coming to market alluding to being able to do photogrammetry, and in all honesty, if you take them all at face value, you think that they're all doing a perfect job, and it's hopefully we will demystify some of that today. And then more importantly, I think we'll go back to the clinical elements of things and say, how do we actually use photogrammetry in our day-to-day practice, and where can we start seeing massive strides within surgery? How do we not only give patients better outcomes, but also how do we reduce chairside time, improve the patient's experience, but also with a reduction in chairside time, increase in accuracy, generally speaking, it becomes slightly more profitable for us once the products have been paid for. So I figured we would start with, oh, that's meant to play. I figured, not sure why that animation's not playing. I figured what we would do is we would just start off with a slight bit of the basics around full arch. So generally speaking, on the top left-hand side of your screen, you will have a maxilla, and it is split into 3 zones. This would be known as the Bedrosian classification, and effectively it splits the maxilla into zone 1, which is your cuspid, your canine to canine region. Then we have zone 2, which would be our premolar cuspid region, bicuspid region, and zone 3, which would be classed as molars. Now, there is technically a zone 4, but we're not going to be talking about that as such today. And then whenever we get into the Mitch classification, that would be the bottom left. So whenever we're thinking of a form of prosthesis, we effectively have to think, what are we restoring? Are we restoring the teeth only? In which case we've got proportional looking teeth. relative to the face and the mouth, which would be FP1. FP2 would be when we are still only replacing the white, but the teeth will often appear a bit longer. There is a bit of a running joke within full arch dentistry that this is known as an FP1 gone wrong. And then we have FP3, which would be where we are restoring both the teeth, the white and the pink, the teeth and the gingiva. Just to start off with, from a surgical perspective, because I'm not actually able to see everyone who's here, I'm not sure about your background. These are some old photos that I took a number of years ago on effectively how do we carry out very straightforward conventional full arch surgery. So again, this is quite an easy case because we have a patient who has been referred in who was already made edentulous. In Ireland, or a lot of the people that I see typically are farmers. This is I don't want to use the term funny one, but this guy is a farmer who had a lot of cattle. He was, one of his cows was in distress whilst giving birth, and he went in to look after it, and it lashed out and it kicked him in the face and knocked all of his teeth out. So by the time he came to me, he was in full complete dentures. And I actually said to him, gosh, you're really, really lucky. To which he was sort of like, I don't feel particularly lucky. I've had all my teeth kicked out. But then I sort of said, well, 3 inches higher would have been a high impact mid-face fracture, and you would have had a complete, Le4 fracture. So he was, I thought, quite lucky. How do we get into the surgery? So effectively, in a surgery just like this, it's already edentulous. We'll go through, we raise our flap. The variety of different ways that you can do this. In this instance here, we've an absolutely enormous ridge. With tons and tons of keratinized tissue. I've opted to go just slightly palatal, but it's completely appropriate to go, into the sulcus and reflect everything back over. There's a multitude of different ways. We get access to the ridge. We profile the ridge based on our prosthetic planning. Personally, what I like to do here, I don't believe you can see my cursor, but what I personally like to do here is I will use some form of guide, whether it will be bony landmarks from my CT scan, or this in this photo, this is called a mallow guide. But I will also draw in pencil where I want my implants to be. And this, you'll see 1, 2, 3, 4 lines, with the most posterior line actually being where the sinus, anterior wall of the sinus is. This is just a little shout out. I quite enjoy using Versa drills just purely because they densify bone, get very good results with it. But as you can see from this photograph, you've got ample space for an implant. Again, we're going down the prosthetically driven route for full arch implant placement. Even though this is an all-on-6 case, I only have 4 direction indicators, so I was just doing them bit by bit for the photograph's sake. But we're aiming for prosthetically driven placements. These are southern implants, so you will notice with the posterior implants, they are look a bit different from the anterior implants. So just as an aside, these are called co-axis implants. The co-axis implant has the implant well milled off angle or at an axis to the implant. It can be in this specific type of implant, 12, 24, or 36 degree of angle correction. What that allows you to do is, there you can see the angle correction of those posterior implants angling at 24 degrees. But what that allows you to do is the implant well, in this case, this is an old case, this is X-hex. It allows us to use straight multi-units, which actually gives us a little bit more predictability when it comes to prosthesis options. Multi-units go on. Something I'm quite keen on is transcrestal suturing. It's really, really good from a soft tissue management perspective. Temporary cylinders go on. Typically for some form of pickup, we will end up needing to use a rubber dam of some sort, something to isolate the implants from the mouth. At this stage in time, we were still welding intraorally. So this was a metal bar that we would have that we would adjust to the point that we were able to connect all of the implants together to give them a bit more stability. And then what we were doing is this was going to a technician or a CDT who was chopping big holes out of a denture to effectively account for our temporary cylinder space. These were then being picked up with cold cure acrylic. But I'm not sure if this video is going to work. There we go. Open up for me, close together. But what you will probably see is we were able to deliver quite good results, same-day surgeries of someone who's had no teeth for a long time, getting them back into fixed prostheses. And this is the way that we have been doing full arch for a number of years. And as you can see, I think actually we still end up in quite an aesthetic result, quite good occlusion straight off the bat. Open up for. There are some more novel versions of this. So the point that I would make is if we look at the bottom of these two photos, what we will see is effectively what I have carried out in the previous slides, which would be a conventional denture conversion. The reason I'm talking about this slide in a photogrammetry lecture is because we will touch on the costs associated with photogrammetry and the digital implementation, but I'm also very mindful that the transition to photogrammetry is not going to happen overnight. There's going to be a lot of clinics who aren't necessarily going to be able to adopt digital as quickly. So for this reason, I still think it's worth talking about more novel approaches to conventional pickups. So across the bottom, you can see a lower denture that has 6 relatively large holes cut into it. You will see the middle photo is exactly what I showed you previously with the temporary cylinders coming through, and then you'll have the final bridge. On the top of the screen, you will see specifically in the middle 6 very, very small holes, and subsequently the second or the third slide over here, that is your final definitive prosthesis. What you will notice is that your holes are significantly smaller, and with that comes more material around them. So you're going to have less likelihood of a prosthesis fracture, which obviously is a bit of an issue whenever we're carrying out full arch surgery. So I'll just briefly touch on this because I think this is a good halfway house before we get into a fully digital approach. Effectively, the way that this works is this is a patented technique. It's actually stemmed from the American Air Force, where effectively what you do is you start off with the patient with a conventional full denture. You'll place your dental implants and you'll put your multi-units on. And then with something like Blue Moose, you'll actually take an impression of the multi-units with the teeth in occlusion. So we get the denture in occlusion, we take Blue Moose, get them back into occlusion, and then on the Blue Moose, it will have effectively taken an impression of our multis. From there, we take like a denture burr and we gouge out a negative space around our multi-units. The top slide in the middle, you will see these little pink things on. These are effectively tie bases with snap caps. So these go onto your multi-units. We know where the multi-units were. So again, you just make sure that you have clearance on your denture. So you'll take a denture burr, you will adjust the underside of the denture to allow clearance, and you always checking the patient in occlusion, as your stable reference point. Once you have enough clearance on the denture, what you will then do is you will actually put cold cure acrylic around the snap off tie bases. Or sorry, apologies, you move on to the top right photo, which is the rubber dam goes on. You will put cold cure acrylic on the underside of your denture and around these tie bases, and you will have the patient bite in occlusion. Now, if you were to do this with a temporary cylinder, you have a lovely occlusion that you then could not access because the denture would effectively be glued onto the temporary cylinders. However, with this, if we look at the bottom left photo, because of the nature of these snapping tie bases, we just can lever this off. The force is quite low to snap them, and then effectively our tie bases are fully in situ. There are 2 drills, which you can see on the bottom of the photos, which will drill very, very small holes, just wide enough for your prosthetic screw. And then it just needs a small polish, and you are going to get beautiful occlusion very, very quickly with a very quick conversion. So pros and cons of this, probably less likely to have a prosthesis fracture, significantly faster in surgery, much more likely to have a good occlusion so long as your denture design is correct. The only downside really is there is a bit of a cost associated with it. It's not horrific, certainly when we compare it to adopting digital, however. So that is the day of surgery. We now have to fast forward to our implants have healed. This would be the conventional way of carrying out conventional full arch impressions. So this will be, typically speaking, a special tray where you have open up spaces for your impression copings, and it would be quite common, especially using materials such as Duralay, to splint the implants together. You'll see on social media or in textbooks, whatever people, it depends on how young people in this group are, what they actually use, but you will see things like floss being tied between implants and then Duralay being put on that just as a sort of guide. But effectively, we were looking at some form of pickup impressions such as this. Obviously, we all understand things about material shrinkage and impassivity, and the whole point of today's lecture effectively is going to be focusing around prosthesis passivity. This doesn't need to be a particularly long lecture as the complexities are all relatively minimal. But once we have our denture, it would be normal for the lab to have to fabricate something called a verification jig. Now, a verification jig is effectively something that you might see coming in multiple parts, and we will just verify it in the mouth, and this will come off. And effectively, this is a way of us saying, are the implants that we're using passive? As you will probably expect, this is a multiple appointment scenario. There are still issues. It's exceptionally technique sensitive. It's quite bulky for the patient. And generally speaking, patient feedback is relatively poor with these options, although this is how it's been done for many, many years. Even with verification jigs, it is still possible to incorrectly verify position. Some of you may be aware of lab side tests. So this would be known as the Sheffield test or the one screw test or the rock test. And effectively, it's a method used to verify the passive fit of a full arch screw retained implant prosthesis. What you would firstly do is you would place your metal framework onto your abutments and you would only tighten one screw. So typically, you're tightening the most terminal screw, like the most distal screw. And then what you're effectively doing is you are rocking the denture and you're seeing if the framework remains fully seated or if a gap opens up. You will typically notice this most if you have the distal screw is the most noted because obviously you just have the biggest lever arm there. Now, there are a few issues with this. So obviously, if you are opening up a gap, then that would indicate a lack of passivity. We're going to be picking up on internal screw strain of our prosthesis. And obviously, all of those things are associated with things like crestal bone loss, prosthesis fracture, porcelain fracture, implant failure. But the Sheffield test is in itself flawed. So the Sheffield test, if we said for argument's sake, one of the implants was not picked up passively, then if you were to put an apical force on it in one direction, you might find that the prosthesis on the other side would lift. However, the issue with the Sheffield test is if the discrepancy is the other way around, then actually pressing down on the prosthesis won't actually elicit a response. So the Sheffield test is within itself flawed because obviously we have an X, Y, and Z axis whenever we're considering anything in three-dimensional space. And if the issue in that vertical, call it Z axis, is your issue, it's not always possible. But effectively what we're looking at, this is just an extra belt and braces approach to reviewing passivity. A 2019 Harvard study looked into this and effectively defined passive and passive fit as the simultaneous and even contact of all fitting surfaces without the development of strain prior to functional loading. And I generally think that this is quite a good definition of fit. I think the issue, generally speaking, and we're going to talk about this throughout this lecture, is what is passive fit. There is no strict definition on passive fit. So I would be very happy if anyone was going to criticize me today on you're talking about passive fit, but what is a passive fit? Because we're talking about a passive fit and not a perfect fit, because theoretically nothing here is going to be perfect. Passive fit, whenever we look at the literature, is very, very poorly described. But effectively, what we're looking for is something like this rather than something like this. It should be the simultaneous seating of everything. The issue with passivity is that there is no defined term on what is passive versus what isn't passive. And the reason for this is because we don't know. That's the honest answer. It is too difficult to actually assess this. So we've got some previous authors citing things like 300 microns of movement. We have some authors citing things like, 150. And sort of more recently, we're down at the 100 microns of discrepancy. But a single multi-unit can have a couple hundred microns of discrepancy built into it. So obviously, if you had 100 microns of discrepancy in one multi-unit, you will then pass that the discrepancy on multiplied. So it just goes back to that lever arm principle. If we have just a discrepancy in one implant, the further away we go from that single implant, the larger the discrepancy will be on our other implants. So what is photogrammetry? So very simply, photogrammetry is effectively a digital way. It's a digital technology that is used to verify implant positions. That's probably the most simple way that you can think about photogrammetry, but then it gets a little bit more specific, where photogrammetry effectively is using multiple cameras, taking photos at different angles of the same subject, effectively using geometry to verify position. So photogrammetry is actually not a dental technology, it's actually a surveying technology, is where it first started life. So if you were doing topographic maps of an area, you would have encompassed big cameras. So if we cast our minds back, so the only person old enough to remember World War II is John, but if we cast our mind back to World War II, you might be familiar of British and German spy planes, where you would have multiple planes flying at the same altitude, taking photos of the war zone below them. And that was a very early indication of photogrammetry, where what they were able to do is they were able to effectively take two photos taken of the same thing from different areas, and they were able to pick up a map of things like surface texture. That's how one of the ways that they were able to identify trenches and bunkers and things like that. So photogrammetry has been used for a very, very long time. More recently, you will see these two images on the screen. The top is called PIC, P-I-C, and the bottom is called the iMetric 4D, or the iCam. The iCam is the camera itself on the bottom right. And this is quite hefty. You know, this thing would be weighing about 10, 15 kilos. These two options were the first options that were available widely, in the ones that we discussed on my systematic review. And I will start talking about some of the other ones in future. But effectively, they are a multi-camera system that is looking at their relative sort of scan bodies, for lack of a better word, to verify the implant position. And we will talk about how there is a difference between the two. The top, you will notice these two big red glowing eyes. Those are the two cameras. And the bottom, you will see four cameras, and you will see significantly more dots on this domino looking thing on the bottom compared to the top. The top one effectively is not photogrammetry, even though it is marketed as photogrammetry. It is technically speaking stereo photogrammetry, as it is only using two images rather than four, and I'm going to touch on that in a second. What does it cost? The cost we'll sort of touch on, I think, in a little bit later on in the lectures. We start talking about some of the newer technologies available. But this has been something that historically has been horrendously expensive. The iCam 4D on the bottom right, actually, it started life out working for the likes of Boeing and Rolex and Formula One. So it has always been a massively precision engineering bit of equipment. A couple of years ago, during the kind of COVID years where supply chains were short, it was about £60,000 per unit. And the dominoes that you can see, the scan flags that you can see, for a set of them, a set would be autoclavable, but I believe only 80 times, cost about £4,000 sterling. So it was very, very expensive. I was actually at a lecture about them recently, where they said due to supply strain eases, this has actually now come down to about £20,000 for the system. So still a very, very significant amount of money compared to some of the more recent additions to the market, although this is the iMetric 4D on the bottom right is still by far and away the market leader in terms of accuracy and precision. So I recommend all of you do not read my systematic review. It is exceptionally boring. Yeah, we will be covering most of that today. Effectively, the long and the short of the systematic review was that at the point that we researched it, photogrammetry was just as accurate and just as precise as conventional splinted impressions, but there was still not enough evidence to say that it was definitively better. And that really just came from the fact that it was a novel concept and there's not enough papers to absolutely disprove that it is better than conventional splinted impressions. So whenever we're considering impressions in general, but full arch verification and photogrammetry, what we need to be considering is precision, accuracy, and trueness. This slide does a pretty good job at explaining it. So effectively, if we were to think about a dartboard, let's look at the one on the top left, we have a small cluster of darts on the top left of this dartboard. So what you would actually say is this is a very precise but inaccurate an inaccurate attempt. If we take the bullseye area as like the true position that we're aiming for, so you would say this would be top left would be high precision, low accuracy, low trueness. The middle slide would be in this case low precision but higher accuracy and better trueness. And with the one on the right being we've got high precision because our cluster is very small, high accuracy as well, and high trueness therefore because it is around our center point. And that's effectively how we think about it. So as we see, we have the future King of England flipping the bird, I believe is the way of describing that. But effectively what we can see here is a good example of stereo photogrammetry. So as I alluded to before, this was the item on the top, which I'm sure most of you have seen this photo before, where we only have a 2-camera system looking at a 2D object. So what you will notice, these black and white scan flags that you'll see on the left of the screen, you will see that they are tall, they are flat and 2-dimensional. So you are taking a photo with 2 cameras of this front surface. However, this is stereo photogrammetry. When we consider true photogrammetry, we consider this. We actually gain a significant increase in information. The reason for this is whenever we actually are taking scans of anything with photogrammetry, you will notice, by the way, this lecture is semi-focusing around PIC and ICAM because these are arguably the 2 market leaders. But all of these principles will apply to the cheaper options that are on the market because it's really important that you actually understand what you're buying. Whenever we look at the ICAM, however, you will notice that actually we've got multiple sides. You have got effectively 2, you'll see there's 10 dots. So you've got multiple dots, but you also have a top surface as well. So you've got 4 cameras all taking multiple views. So you have a significantly higher precision and accuracy comes with that compared to a 2-camera system only working on a 1-dimensional slide. So the process of doing a verification jig and all of the impressions, typically it's a couple of appointments, and most people will take a couple of hours to do that potentially, especially when you're not familiar. I actually have a video in a second. This technique is typically only about 30 seconds from start to finish, so it's significantly faster than anything that we have done analog. This is just a good example of what the camera would be seeing, for example, if we're using the iCam because of the 4-camera system. And the next video, this is in real time. You'll see the dominoes start off red, and as we go around the patient, they will go green. And once the implant positions are green, the camera has validated all of the implant positions. So as I say, this is a real-time video. Which really goes to show you just how quick this can be. But I feel that this is a good opportunity to also talk about some of the issues with photogrammetry. So if we take both of these 2 systems, what we will see is, you'll notice in this video that everything is black and white. All this camera looks for is the implant positions. It is not able to give you anything to do with the patient occlusion. It's not able to give you anything in relation to the soft tissue. This purely acts as that verification jig to pick up on your implant positions. And that is arguably one of the drawbacks of these technologies, is they are pure to looking at implant positions, but they are slightly, pardon the pun, one-dimensional. Just before we start touching on some of the novel technologies, before we go back into the clinical implications of this, which is much more enjoyable to talk about because this is all a bit boring in my opinion, is how much is the camera actually seeing? So whenever this is based again off the Harvard study, they were effectively looking at the PIC camera, which had two cameras, looking at 4 targets. So those were the black and white dots that you're seeing, versus 8 targets versus 19 targets on each of the ICAM scan bodies. And effectively, if you have a little look, there's significant redundancy. So what that means is there is so much more information captured when you have more of those little dots compared to less of those little dots. And obviously, again, more cameras is more information, is more accurate. We're now going to start moving into a little bit about newer technologies that will be on the market. I think off the top of my head, I can't remember if this one's called the OXO or the Micron Mapper, but you will also see that these scan bodies are circular in cross-section. So anyone who understands digital scanning knows that this is an absolute load of crap, because anyone who's tried to scan a scan body that's completely round will know that it's really difficult for an intraoral scanner to pick it up. Whenever we're considering geometry, we want straight lines, we want definitive points, okay? If we have something round, it defeats the whole premise of accuracy and precision. So the first thing that I would say is anything that you're looking at that has a round surface on it, as the capture surface, don't bother with it. It's never ever going to be accurate. This specific product, actually, the rep had come out and spoken to me about this one day, and this comes with 6 of the scan flags. So we were talking about what if I did an all on 6, where I had 4 implants in zone 1 and 2, and I had 2 implants in the pterygoid region. And he said, oh, well, this does something very clever. You could actually put your 4 scan flags in at the front, and then you could take out the 2 from the front and put them at the back into your pterygoid region, and then the camera will stitch the 2 together. And he thought that this was fantastic. And I said, that's absolute crap, because if you're stitching 2 things together, you're using a best fit algorithm. If you're stitching 2 things together, you, by very definition, do not know exactly where they are. You are using some form of technology to try and guess where they're meant to be by using those middle 2 as a reference marker. But again, that completely flies in the face of what photogrammetry should be. So again, whenever you're doing this, it should always be all of your implants being recorded at the same time. These are some of the more recent scan flags that you will see on the market. You will see on the top left of your screen the golf club shaped one, which is PIC versus ICAM, versus your Micron Mapper or OXO, and then the bottom is shining. This is something actually even I learned relatively recently. We're going to talk a little bit about, this is such a fun topic, coefficient of thermal expansion, and how it pertains to accuracy. So there are different materials on this. So some of these, so the golf club looking one is plastic, versus the ICAM scan body, which is the second one in, is made of metal. And plastic has a significantly higher coefficient of thermal expansion. So whenever we're considering like we're talking about micron accuracy, so a thousandth, a thousandth of a millimeter. If we have something that expands more in the mouth, it will obviously get less accurate, because all of these are tested at 20 degrees Celsius, and the mouth is going to be not 37 degrees Celsius, because obviously we've got air getting into it. It's going to be somewhere in the middle. So generally speaking, an ideal scan flag for photogrammetry should actually be small. not long, because obviously the longer something is, the higher the degree of thermal expansion. But it should also be something that is not going to expand much. So it should ideally be metal. So you will see on the bottom, this is the Shining 3D, which I have also started to use, and we will show at the end of the lecture. These scan ladder type approaches where the actual scan body is quite long and overlapping, they, just due to the nature of how long they are, will have a higher degree of thermal expansion compared to something like the ICAM. That being said, it's probably less than something that's plastic. But apparently, each of the Shining will increase by up to 20 to 50 microns each. So that will obviously bring in a level of inaccuracy. So if we've got, for argument's sake, 100 microns of inaccuracy that we're allowed to play with, if we're getting 50 to 100 purely off thermal expansion, it doesn't leave us much room, which we will touch on just in a second. So that's, I think, just something very interesting. The other thing just to talk about here is something called tolerance stacking. So tolerance stacking, so if we think about conventional dentistry just for a second, okay, and we think about how a crown is made. Whenever a crown is made, we will all appreciate that the crown is not the perfect match of the prep. The crown should always have a slight amount of space within it known as the cement gap, because if it was an exact map, then we wouldn't be able to get any cement in because there would be not enough space for cement. So whenever we're considering a cement gap, that is by very definition a degree of inaccuracy. So where do we develop inaccuracies within dentistry? Well, if we think about a full arch prosthesis, we are going to be cementing tie bases on, so therefore all of those tie bases will have a cement gap in them. You will see more and more that people are using zirconia and they are going direct to multi-unit with zirconia. And the reason for that is it is one level less of inaccuracy. Okay. Other things to think about will be the difference between printed materials versus milled materials versus zirconia or a metal substructure. Because generally speaking, if we're going down the route of a printed material, you will have a significantly higher amount of inaccuracy compared to a milled compared to a metal framework or zirconia. The type of intraoral scanner you use will bring in some levels of discrepancy as well. Certainly with your photogrammetry system will bring in levels of inaccuracy as well. So whenever we're considering tolerance stacking, when we're thinking about our final prosthesis, well, we're trying to stack as many things in our favor as possible. So, you would be saying, let's use the most accurate photogrammetry system with the most accurate final prosthesis material, which might be zirconia, potentially also going directly to multi-unit because all of those things are minimizing issues. As we increase issues, we're increasing the strain on our implants. We're going to then, technically speaking, have issues with impassive fit. Just because you can screw down a prosthesis does not mean it is passive. A level of impassivity of 200 to 300 microns is not perceptible to the human eye. Okay, certainly not at multi-unit level because you can't see the things fitting. Okay, but the difference is you will start to develop strain within your implant components and your implants themselves. The Shining 3D, I want to talk about a little bit because I will be talking about it. All of the systems up to now are effectively ways of verifying implant position, but that's it. You still need to have the likes of a Trios or an iTero or some form of intraoral scanner to confirm your occlusion, but also to confirm your soft tissue. The Shining 3D launched, I believe, 2 years ago. We've bought one and used it successfully. Hopefully everything you've heard today will highlight that it is not actually photogrammetry as much as they do claim it to be photogrammetry. But I do think it deserves a special mention because whilst it's not technically speaking true photogrammetry, it does deliver, I think, an excellent value for money. And I'm not here, sponsored by any company. I'm just giving my, if we look at the pyramid of evidence where we have meta-analysis at the very top, we have expert opinions, and I scarcely would call myself an expert, but in this I probably have slightly more knowledge than other people. The Shining 3D works completely normally as an intraoral scanner. You can use it as any single part of your workflow. However, it will also be able to verify your implant with photogrammetry and inverted commas. Um, Whenever we're thinking about photogrammetry, the two cameras ideally should be spaced wider than the implants themselves, okay? Which is why you'll notice the extraoral cameras are going to be, generally speaking, about the width of your eyes, let's say, which is obviously wider than the inter-implant distance. This uses, the Shining 3D uses two cameras built within the actual scanner itself, which by very definition are not going to be wider than the implant position. This isn't specifically an intraoral scanner scanning a scan flag. This is technically a almost photogrammetry approach, so it's not like the likes of grammetry. I'm at a Straumann conference. I'm really happy to shit all over. Sorry, apologies, to slag off the Straumann version of this, where they effectively just glue scan bodies together. It's absolute rubbish. Please don't buy it. It's just a waste of time. But the Shining 3D, I think, offers the best kind of hybrid of everything. So I'm going to hopefully show you a bit of that in a minute. Bits that I think people actually want to know about are DICOM matching and CAD matching, because this is the future. This is how we're going to make more money. This is how we're going to push the limits of what is possible within a dental setting. So we'll touch firstly on DICOM matching. DICOM matching, I think, is really clever, but it is quite technician heavy. So effectively, DICOM matching is you need most CT scanners, if you have an older one, might not be up to the task, okay? But effectively, what we're doing is we are taking CT scans of the patient before and after surgery. So we are not reliant on matching anything within the mouth. We're not reliant on matching soft tissues or scan flags. We're actually matching something much more stable, which is going to be the patient's skeletal base, okay? This is quite an old video of point matching. There are now AI versions of this which are far better. So you've seen here, what is that, like 10 points, for example? And we're going to use a best fit algorithm, and you'll see it in a second, to effectively pull these together, and you'll develop a heat map. This is about 4 years old, this video. New AIs will put thousands of points on and will develop a significantly higher best fit. But effectively, what we're doing here is we're just segmenting the mandible from the maxilla, and it just allows us to do a best fit of both the maxilla and the mandible independently of each other. What that allows us to do is, for example, if we have a scan pre-op of a patient in ICP, or let's say you're not conforming to ICP, you're going to reorganize the occlusion. We have a scan of a patient in there, let's say you're using a denture, you regged in CR, we're going to get the patient in the CT scanner in your desired occlusion. So it doesn't matter. I don't care how you're getting them in occlusion. I don't care if you're reorganizing, conforming. What we're actually doing is we're getting them in their definitive occlusion in the CT scanner. We are then taking a CT scan in that position. What that then means is we can then fast forward. We have their actual, we talk about articulators, hinged, semi-adjustable, fully adjustable. There's nothing better than the patient's actual skeleton. That is the best articulator that we can have. We don't need to think about condylar guidance angles because we have the actual condylar, condylar bodies, and we have the articular eminences. So the best thing we can use is the patient themselves. Thereafter, it does not matter if the patient is in occlusion after that post-surgery, because we have their CT scan pre-surgery, we section the mandible and the maxilla, and then what we do is during our surgery, we put our implants in. We immediately verify the implant positions with photogrammetry. Again, I would recommend that we do this with soft tissues not closed, because what you can see, you can't see my cursor, but what we can see is that you can actually see that all of these are fully seated, okay? And you're going to have less issues of tissue entrapment. We take our soft tissue, we take our photogrammetry scan. We then send that to the lab with a post-op CBCT scan, and we take either an impression or a digital scan of the soft tissue. The lab is able to stitch all of that together, design the final prosthesis. It can then print it. And then same day, we have the patient perfect occlusion because it's based off the patient's pre-op, pre-op occlusion, straight in. TAD matching, I think, is slightly more accessible to most people. I think people can get started with this pretty much straight away. But essentially what we're doing here is the workflow for something like this is, let's say, when we're doing our diagnostic stages, we are designing our final prosthesis at the very, very start. Okay, and that gives us a couple of benefits. It allows us to think about where do we want to place our implants, if we want them to come out various areas, but we are doing our DSD, our smile design, at the very start of surgery. So we have an intraoral scan of the patient at the very start. What are going to show this slide first. The next thing that we're going to do is we are going to take a slide pre-surgery. So this is before the patient is in, this is day of surgery, but this is before we've made an incision. We are going to put John, can we see my cursor by any chance? No? No, okay. For this, what we're going to do, we're going to just do a little drop of local just into the midline suture, like into the midline of the palate, and we're actually going to drill into the palate and place 2 specific scan flags. I'll show them in better detail in a moment. We're then going to take another intraoral scan, exactly like we had of the patient pre-surgery. What that will then mean is the lab have the teeth pre-surgery, which is what they've done their diagnostic wax up on. They again have another scan of the teeth pre-surgery, but this time with 2 scan bodies in the middle of the palate. The next thing that we are going to do is we are going to take our teeth out. We're going to put our implants in, and we are now going to have another scan of the soft tissue. So what you're going to do is you're going to mesh them together. So hopefully you could see the scan of the soft tissue in a second. I'll show it to you again. And by meshing the 3 together, we have teeth pre-op. We then have teeth pre-op with scan flags in the palate, and then we have no teeth with scan flags in the palate. And whenever we actually look at the match between them, we've got 0.025 millimeters of discrepancy. So very, very little discrepancy here. What then that allows us to do is our lab already has the patient in occlusion based off the pre-op scan. They have the post-op soft tissue. We then have to, is it this video here? Oh, sorry. We then are able to bring in the implant positions using our photogrammetry. And now we have everything that we need. So here you'll just start to see in a second. Those are our implants. So no verification jig, no impressions, nothing like that. This is going to be more accurate, faster. We now have our implant positions. We have our soft tissue scan. It is just from the lab perspective. All they have to do is they have to match the soft tissue to what the scan is, and they have to bring in the implant position, and then it is just a case of printing. Now, this system that I've just used here and the previous system were done with ICAM. The next slide I'm going to show you is a patient that I saw just the other day. I'll give you a little bit of a background around her. Her implants have been in for about 10 years. She was smoking up until about 2 months before this photo, where we got her to quit. You will notice that the lower incisors is a bridge, so she had failing lower incisors. Her oral hygiene has not been fantastic, but trust me when I say this is the best it has ever been. What I did was I have extracted her lower incisors and given her a resin bonded bridge that actually overlaps onto the canines. So we understand that her lower dentition is terminal, but we're trying to keep hold of it as long as possible. We've had about a 3-month stabilization phase. This is actually the teeth looking as good as possible. She did apologize for not having brushed her teeth before this, but I can guarantee you that this is all soft plaque from this morning's breakfast. This is not calculus, so actually we're in as good of a position as possible. There is calculus on the top. Those teeth are swinging in the breeze. I kind of just said to her that these are them very clean, but there's not much more she can do about that. So how did we look at this surgery? So here we've got our maxilla pre-op. Here we've got our mandible pre-op. I spoke earlier about the little scan flags that go into the palate. That's what they are here. There are two types available. You can get one with a 6mm screw, or you can get one with an 8mm screw. Generally speaking, the 6mm screws typically go in the posterior mandible, with the 8mm screws going into the maxilla. The thing you need to kind of factor in is these cannot move during surgery. Okay, I don't have patients ever complain about this post-surgery. These are very, very small screws, realistically, especially when we're considering how invasive a full arch surgery is going to be, but these really have to stay in, and they cannot move through the duration of the surgery. So if we use a 6mm one because you're trying to be kinder to the patient, but let's say you only have you have 3mm of soft tissue thickness, that's only 3mm of this engaging bone. I wouldn't rely on that. So that's typically the rationale for why the 8mm ones are used in the palate. Again, if we're thinking about the geometry of how we would do this, that we're going to be thinking that we are going to get a significantly better match if we have two scan flags in the palette. So it's always advisable to have at least two. One is going to work, but two will work better, okay, from a matching perspective. It is important that you think about where these TADs go, because if you're going to try and reflect your flap directly into one of these, you're going to have a problem. So generally speaking, with all of these things, you want to have them as far apart from each other as possible. And you want to have two. You don't need more than two, in my opinion. I don't think you'll be able to get more than two in. But ideally, if you could have two spaced quite far apart. You will also notice that these are not round, these are straight. These are all straight lines everywhere, which makes a match going to be significantly easier. Again, we're using a stereolithic stent to guide our implant positions. You will notice that I have hand cut out where I've put the TADs. I actually asked the lab, do not make a component, do not try and guess where I'll put the TADs in. Give me a full palette and I will just manually cut these out, because you don't always know what it's going to be like until the day of surgery. Again, we are using, so this is the pick, or sorry, apologies, this is the Shining 3D. You will be able to see that this is fully seated. We've got this at the very start. Now, when it comes to actually verifying these things that I could have done better, I probably could have spent a bit more time cleaning the scan bodies, although it's not as important as you'd think. But the way you kind of want them to work is these scan bodies are all overlapping but not touching. You should be able to see daylight between each of the scan bodies for a couple of reasons. If they're touching, are they putting pressure on each other? Have you effectively got them touching and torque the screw down? And is there flexure in one of the scan bodies? You don't know. So if they're very, very close but not touching each other and you can see daylight in between them, the scanner will pick that up better. This is the photogrammetry part of the scan, and then this is the soft tissue part of the scan. So this is a second scan. So once you do your photogrammetry scan, you then take it out, you screw these in. This will give us our soft tissue match, and it will match it to our pre-op occlusion. So this is just straight off the scanner online portal. So it allows us to see our pre-op situation, and unlike the iCam 4D, this is also able to do our sort of quote unquote photogrammetry and our soft tissue scan and our occlusion. And this software is very clever because it actually automatically stitches it together. So it's not like your lab have to do this and learn how to do this. This is actually, pardon me, this is actually all done automatically for you. The patient is now in occlusion based off their pre-op occlusion, or if you were using a reg rim to get them into a reorganized occlusion, you would scan them in the reg rim. But now you've got your implant position, your soft tissue position, and your pre-op occlusion. This then goes to the lab, and just like I showed you in the previous videos, this gets designed. The design phase with a technician that kind of knows what they're doing is typically about 45 minutes. They can be anywhere in the world. They send it back to you. You would need to have an in-house 3D printer. The next thing I'm not massively going to talk about, just for time's sake, is going to be material science, but you would be needing to use a nano composite. So these are much, much, much stronger than conventional resins. They are about the same strength with modulus of elasticity of milled PMMA. So these are really, really strong. Okay. And if you're unsure, you can always have your technician sort of overbuild them for increased material thickness. We've been very lucky that thankfully we haven't had any fractures even on bruxist patients. But that is a little bit about the actual that is a little bit about the um, clinical applications of photogrammetry and how it can actually be used in day-to-day practice, how it can not only increase patient satisfaction, but also significant. If you think about this, we're not doing a denture and a conversion and then having to redesign once these implants have healed. This is the definitive final bridge design on the day of surgery. You can then, it depends on what system you use and your tolerance, you can actually take a brand new soft tissue scan after 6 to 8 weeks. And then you can deliver your final prosthesis, the appointment after that, and you can really shrink this down. We have, as a proof of concept, actually delivered the final prosthesis 24 hours after surgery. This was done. I don't recommend you do this. It did work fine, but this was only a proof of concept where we said we would cover the cost of a second bridge if needed. Where actually what we did is we did our photogrammetry. We printed the bridge on the day of surgery. That was the final design. At the same time that one bridge went to the printer, we have an in-house mill in the clinic I used to work in. We then sent the other bridge to the mill where we milled it in zirconia. That was sintered overnight, stained the following morning, put back into the furnace and glazed. And then we fitted the zirconia bridge the following day. The way we accounted for soft tissue is that we just put the bridge under slightly higher soft tissue compression. And whenever we reviewed that 6 months later, there was absolutely no issues. Now, we were able to do that at an in-house lab. Oh, sorry, I'm going to have to say that is not my email address. Please do not email that email address because you will not get a reply. While you are here, John, am I still sharing my screen?
No, you've come off.
Well, while I'm here, let's just change that. Info@drtommurphy.com. There we go. That's much better.
You're very accessible by your Instagram as well.
Yeah, that's my email. Can you see that now?
Yes, I can.
Yeah, fine. That's my email address now. If anyone does want to email me, by all means email me. Although I would say that Instagram is probably the thing that most dentists will actually message me on. And I'm quite happy to chat about this if anyone wants to go into it in any more detail. But yeah, listen, I appreciate it can be sometimes a dry topic, so I try to go clinical, dry, clinical, because most people here, I'm assuming, are clinicians and not statisticians. So with that, thank you very much. Thank you for listening. And if anyone has any questions, I would be more than happy to do my best to answer them.
Fantastic. Thank you very much for your time, Tom. That was really interesting. I found it's really from sort of when I remember when you were writing the your review a few years ago, and that sort of it was a very novel technology for us to be sort of using intraorally, and now that we're sort of combining it with sort of AI and sort of that level of degree of software and CT scanning, I think that's absolutely fantastic, and I think that going forward, I think this is going to be game changing for us, and yeah, so let's have a look at some of the chat. So do you think that sort of photogrammetry is exclusively better for full arch patients, or do you think that it has a niche in sort of the partial dentate? So where those sort of patients where they may have sort of like maybe a 2-3 bridges and stuff like that. Do you think it'd be worthwhile?
Some labs. Yeah, some labs have already said that they are only going to stand over their bridges if they've been done with photogrammetry, and that's for your fixed bridges. Your 2-3 implant span bridges. Yeah, it does not need to be full arch. Full arch is obviously the time that you're going to see, like your level of inaccuracy is going to be higher when we have 6 things over 8 things, or sorry, over 2 things. You will actually, if you read any of the papers on this, you will actually see, and this is where my own systematic review falls foul, and I, if I could be arsed, would change it. Some of the papers that actually talk about where you will develop inaccuracies will talk about how photogrammetry becomes less accurate at 6 implants rather than 4 implants. So the thinking was whenever you bring in those extra implants, that's actually the cause of the inaccuracy. That is not true. And the reason it's not true is something called compensation. The easiest way for you to think about this is, let's say you are sitting on a chair, okay, with 4 legs. If one of the legs is slightly short, yes, you might be able to rock and notice it, but generally speaking, if you're sitting on a chair that is slightly short, you effectively still have a 3-stool, like a 3-leg stool, and you will be fine because those 3 legs are compensating. Once you start adding in more legs, it's going to be easier for you to sit and see that one of those legs is short. So actually, and again, this comes from the engineering side. Like, we are dentists first and foremost. So whenever I was speaking to the guy who developed the iCam, he is he's an engineer. And like he, in no uncertain terms, was just like, you guys are dentists trying to do engineering. We're engineers doing engineering, and your research is all horrendously rubbish because you're not engineers. And I think that's completely true. I'm not an engineer. I'm not a statistician. I find that difficult in my review. But he actually was able to debunk and say, no, this is why your papers are finding, that 6 is worse than 4. It's not that 6 is worse than 4. It's just you are realizing the problem more obviously than 4. But to answer whoever's question that was, yep, 2 3 unit bridges. That's exactly what this technology is going to be used for. Again, something like The Shining, I think, will really shine in those situations. Pardon the pun. But because you're sort of able to use the one system. Now, is it going to be as accurate as an iCam? No, I don't think it is. It does bring us into the next thing of, at what point does something go from being statistically significant to clinically significant? Okay. And the answer is literally nobody knows. ICOM are actually the first people to say that they don't know at what point something becomes clinically significant. They just say, well, if we don't know, why don't we just aim to be as good as possible? Because and the issue that they bring up is they say, okay, well, let's say 1 in 100 of your bridges is impassive and has the problems. That's not that bad. But they said that if that was in an engineering perspective, and 1 in 100, because this is used for Boeing and Airbus as well. If they were like, well, if 1 in 100 airline engines failed, there would be pandemonium. So they're like, dentistry seems to have a higher acceptance of failure than most engineering companies will. But long and the short of it, I do think that something like a Shining 3D could be a good answer to how do we manage our smaller bridge units, because you're scanning the soft tissue. The implant workflow is really, really good. The UI compared to Trios maybe isn't as glam or as refined, but it's a really, really sensible workflow for even capturing your emergence profiles. If you wanted to add in your photogrammetry on top of it, you're going to verify those implant positions really well. So to answer whoever's question that was, yeah, I do think that it does have a remit in smaller unit cases as well.
I assume that would be a really good launching point as well for people wanting to get into photogrammetry, that maybe something like the Shining 3D would be where they may start. Would you agree?
Sorry, you cut out there.
Sorry, I was saying. So, do you think that this sort of the Shining 3D would be a good starting place for people to get into sort of photogrammetry in their own practice?
No, so I actually don't recommend. Well, yes and no. I don't recommend anyone buys the scanners anymore, the photogrammetry scanners. The reason is these were all being marketed to dentists, and the thing is, unless you're doing a lot of full arches per year, I don't really think that you can justify the purchase price. However, the biggest purchaser of these now are dental labs. So most dental labs are starting to do this for free. So there are a number of dental labs where if you say could you come and do an ICAM scan for me? They will do that. Like they'll build it into their cost effectively, but they're effectively doing it for free because they now know you're going to go and get their you're going to get the final bridge from them as well.
Yeah.
So, you know, since I've left the clinic that I used to be in, I don't have my own ICAM unit, but I do have a lab that like flies to Ireland, you know, and does my ICAMs. Now, whenever they're flying to Ireland, they do just say, look, can you like do more than one? Can we do 3 or 4 patients all on the same day to make the trip worth it? But, you know, certainly geographically, I'm in a worse position than I imagine most of the people in this lecture are, who are probably based in Great Britain rather than, you know, on the mainland, as Northern Ireland like to call it. Uh, so that would be my answer. If you want to get into photogrammetry, I would personally just reach out to a lab. The Shining 3D, I think, is really, really good if you don't already have an intraoral scanner and you don't have a lab that is going to be easily accessible to you.
All right. What do you think about ScanLadder?
It's kind of like the Shining 3D, but it works off iOS instead. And whenever we published the systematic review, we literally couldn't include iOS because it was so bad. So there's like whoever, Joanna, I don't know if you can turn your mic on, or maybe you can write in the chat, what intraoral scanner are you using with your scan ladder? Because, and just while in case she is hearing this or not, different scanners, Prime Scan's one of the better ones. Okay, so like Prime Scan and Trios are some of the better ones. Some scanners are absolutely useless at stitching. So they're fine for single units, but not. Prime Scan, Trios are probably the 2 best ones, I would say. I think that, look, everything works to a degree. Scan ladders work to a degree. The whole point of this lecture is hopefully going to show you that, like, just making you aware of what is out there and the limitations. The way that a intraoral scanner works, your STL file, the way it actually works, is not going to be as accurate as a photogrammetry. And if you're looking at doing full arch, especially if you're looking at doing a broader range of full arch, if you're going to use something like scan ladder, where you already know, where I've touched on, the longer the scan ladder, you know, the longer the scan body is, the more it will expand in the mouth. Therefore, the less accuracy you will then have in the mouth whenever you're doing those scans. You know, if you do it, you will probably be fine. Will you have a degree of impacivity on your bridge? You might not know. You might develop screw loosening, which is your best case scenario of a problem, right down to crestal bone loss or implant failure. The whole point of photogrammetry is just removing a variable. You know, why has an implant failed 5 years? Because they don't fail straight away. You know, why has an implant failed 5 years from now, 10 years from now? Is it the bridge? Well, if you can cross off the bridge from an impacivity, it just makes your life easier. So what do I think about it? I wouldn't use it because I have systems in place, like working with labs that do photogrammetry, you know, which makes my life easier. And it's going to be more accurate. I'm not going to have to worry about fit, where I always think I probably would worry a little bit about fit with a scan ladder. So hopefully that answers your question. I personally wouldn't use it, but that's only because I'm so, yeah, you're welcome. There you go.
And Sven asks, so the difference between using a conventional intraoral scanner and photogrammetry is the number of cameras and the stitching of the images together instead of having a single image.
Yeah, that's sort of like, I actually, again, like, I'm not an engineer and I'm not gonna pretend to understand how this like patented camera works, but whatever way it does it, yeah, it's different from the way an STL works. And again, it goes back to the fact that you've got the cameras which are spaced wider apart than the implants themselves. And that's why, so Sven's sort of asking about like intraoral scanner versus photogrammetry. I would almost split that into 3 things, which would be photogrammetry, intraoral photogrammetry, and not photogrammetry scan flags, which would be like a scan ladder. So your photogrammetry, which again you can split into stereo and real photogrammetry, is outside of the mouth. The cameras are spaced wider apart than the implant, and that's what's giving you the higher degree of accuracy. 4 cameras being better than 2 cameras because of the images you saw earlier, you just get significantly higher capture. Intraoral scanners, again, yeah, there does seem to be, when I was like reading up on The Shining, like there does seem to be a very specific like step change in even how the scanner itself works, because it can obviously work as an intraoral scanner, but then you have to change tips, and then it uses different cameras to do its photogrammetry thing. So yeah, I do think that they're like, I'm not an expert on how the internals of various scanners work, but there is definitely a difference where you've got a multi-camera system even within the scanner head compared to a single camera system, which is just point matching, which is what like a scan ladder will do, or if you're scanning a conventional like scan flag or something. So I still think it's the multi-camera system even within a single intraoral camera head, if that makes sense.
Yeah, fantastic. Sven seems to be happy with that. And
Sven's always happy.
He's always happy. He's
Sven's always happy.
I hope you keep him well, Sven. We'll give people just a couple more minutes just to put their questions into the chat. I'd just ask as well, do you have any advice for people that might be wanting to get into full arch as well? Or because I know that you're very experienced in that sort of thing, or into sort of pterygoids and sort of that sort of thing as well. Do you have any advice for people that might be wanting to do that?
Yeah, I mean, I've got loads of advice. My honest and like quite awkward way of answering that is, it probably like depends on what stage you're at. So like if anyone does want advice on how to like branch into full arch, or if they're doing full arch and how to extend it into something else, then like I'd be more than happy to answer those and be like specific. My kind of generic answer is do what most people would recommend, and it is just suck it up and pay for a mentor, and that is ultimately it. You will either pay for a mentor or you will pay for someone to fix your mistakes, and I can guarantee you the second one is significantly more expensive, significantly more scary for you because you've made mistakes, and patients are aware of this and patients can come to harm. So the value of a good mentor cannot be understated. Please actually like consider who your mentor is. There are so many people mentoring now. We worked with one guy, and I'm not going to name names, but he'd been like recommended. He'd done like a full arch course and then had said, "Oh, I teach full arch," and he came in with us, and I was asked if I would mentor him through the upper arch, where I would do the upper arch and then he would do the lower arch. So I'd left the room because I would do my own conversions. We didn't have a technician there. And I came back in to see this guy who mentors full arch doing the lower arch. And it was just a train wreck where the implants were all the wrong angle. They were too superficial, so there's a lot of people will say that they are mentors, but, if you're only starting out, like you could have done a million singles but never done a single full arch, and like you're not any worse of an implant surgeon, you just do different types of implants. But there's such a massive, like that Dunning-Kruger, you don't know what you don't know, and there's a lot of people will be able to charm you and tell you that they're the best thing since sliced bread, and I was I'm actually gonna show this because I showed John and Alan this last night. This is a keynote speaker from this Strymon. I'm more than happy to talk shit about this because this was horrific, right? This is in front of thousands of people, right? We can all appreciate that whenever we're doing an implant bridge, it should be cleanable. Okay, implant should be in a good position at good angles, and it should be cleanable. I hope you can see this, where this central incisor thing is like ridge lapped. It's absolutely not cleanable. Okay, like this is someone who like on stage is saying I do 3,000 implants per year, right? Which if you actually break down how many implants you do per day, that is ridiculous. You know, everything about this is wrong. You know, so there are people who are doing 3,000 implants per year who are like lecturing on stage here at this conference, and like it's still absolute rubbish. So please, please, please be diligent who you actually are getting to mentor you. Please, like they should have plenty of instances of showing their own work, you know, online, but you know, be like, you know, reach out to people who lecture and present. And it's hard because like that's being presented, so you're going to assume that that must be good if you don't know what you're talking about, and that's always the risk that you run. But please at least make sure whoever's mentoring you is appropriate. That's the other thing, because mentoring is very, very expensive sometimes, and you want to make sure you're getting good value out of it as well.
Fantastic. Well, thank you very much, Tom. We've really enjoyed having you on this morning. I'll leave you to get back to the conference, and for our delegates, please, in the next couple of days or so, Amy will be sending out feedback, and you'll be able to get your CPD from that. And then our next meeting will be, as I said, on the 22nd of November with Whale, talking about full arch and immediate loading. So thank you very much, everybody. And unless Alan has anything else to say.
No, just
and
a final thank you to you both. Thank you, John, for running a nice show, and Tom, thanks very much for that. That was really, really interesting. So and also thanks everyone for joining, and hopefully we will see you in 4 weeks' time.
See you then.
Yeah.
Thanks,
you guys.
Thank you very much.